Hello, my name is Kevin, and I'll be presenting on disparities in health and healthcare in the US. So, throughout the video, it is my intention to explore first what are health and healthcare disparities, then explore why do health and healthcare disparities matter. Following this, I will then discuss the current state of healthcare disparities recorded in the United States, then move on to some of the challenges that we faced in regard to addressing health equity in the United States, and then finally end with a discussion about how we can drive action towards reducing disparities in both health and healthcare. So to begin, I wanted to start by talking about how disparities in healthcare are caused in the first place, and then I'll move on to discuss what disparities in health and healthcare actually are. So, health disparities are essentially caused by the absence of health equity, and according to the Robert Wood Johnson Foundation, which is a philanthropic organization that focuses solely on improving health equity and policy change in order to address systemic barriers to healthcare, the group essentially defines health equity as the ability for everyone to have a fair and just opportunity to be as healthy as possible. And in order for this to be accomplished, they argue that we must remove the obstacles to health, such as poverty, discrimination, and their consequences, including powerlessness and lack of access to good jobs with fair pay, quality education, housing, safe environments, and of course, healthcare. That said, when we live in a healthcare system that mirrors the one that we in the United States currently have today, it's safe to say we don't really have health equity or at all, but instead health inequity, which causes the structural or institutional patterns and behaviors, which ultimately result in the disparities in health and healthcare that we unfortunately see today. So before I begin to touch on health and healthcare disparities, I want to show you this short clip created by the Yale School of Medicine that discusses the transformation and change in our system in order to reach equity in both health and healthcare. So I'm going to begin sharing my screen so you can watch the video.
When COVID first hit on day one, initially we were all in the same boat. The entire world was not immune. It's a new virus. Everyone felt they were at risk. What became apparent readily and quickly was that we're not all in the same boat.
The disproportionate impact of COVID-19 infection and mortality experienced by people of color highlighted longstanding disparities in underlying conditions that we know are linked to severe COVID-19 illness.
We've all really had this collective witnessing to how differential and quite frankly limited access to resource and opportunity can negatively affect entire communities.
Health equity is when everyone has the ability to achieve their best health possible.
Everyone has a fair opportunity to be as healthy as possible.
And when no one is disadvantaged from achieving this potential because of their socioeconomic position or other socially determined circumstance.
Health equity is opportunity. It really is making sure that people don't find doors closed that should be open.
In order to get us all living our best life, you have to attend to all the structures and institutions that put people at a disadvantage to start.
Equity in health recognizes that individuals have different healthcare needs in order for them to achieve their best health possible. Equality is providing equal care for everyone.
You know, I think a statistic people often find surprising, maybe even staggering, is that if we think about kind of what contributes to your health, you know, it's a small piece of that pie that has to do with healthcare, you know, somewhere in the order of 20%.
Health means more than simply getting the medicine or surgery. That people have access to jobs, fair income, housing, educational opportunities, living in safe communities.
These are larger drivers of health, as it turns out, than healthcare.
And so equity really attends to that difference from the very beginning. That's baked in to the institutions and structures that exist here in the US. And, you know, there's no kind of group where it's more evident than people who've been incarcerated. Black and Latino people are disproportionately incarcerated. Poor people are disproportionately incarcerated.
Through all different types of cancer, we've found that Black patients, Latinx patients, people from underserved communities, and also the elderly are not adequately represented in clinical research studies, are not receiving the care that they need, and they're experiencing worse outcomes.
These realities sadly predated the pandemic, and COVID-19 took advantage of them and laid them bare. So I think the question for us is, now that we all know, what do we do?
And how do we make our health system work for those that are most disenfranchised, those most vulnerable to poor health outcomes? And this is the task at hand, I think, during COVID.
So it's important to have historically marginalized communities represented to ensure the effectiveness of therapies and interventions.
We want to make sure that we are opening up access to the full population. How are we empowering local communities? How are we democratizing the generation of new knowledge? Meaning, are we sharing data that we're gathering?
At the Yale Center for Clinical Investigation, we feel very strongly about the relevance and importance of community engagement. We work closely with the cultural ambassadors who, for over a decade, have really been advocating and advancing representation and inclusion in clinical research.
In bringing people that have been incarcerated into our scientific team, because we have a really diverse team, we're asking different questions.
Trust has to be rebuilt within these communities. Institutions must acknowledge medical and research abuses that have rightly earned medical mistrust and systemic racism as a root cause of distrust and receipt of lower quality care.
And health equity research is our chance to make the invisible visible, and not to stop there, but then to connect the dots between the research findings and policy and practice transformation and change. That is the power of health equity research.
All right, so I hope you enjoy that video. And so with that being said, according to the Henry J. Kaiser Foundation, health and healthcare disparities refer to differences in health and healthcare between various groups. A health disparity refers to a higher burden of illness, injury, disability, or mortality experienced by one group relative to another, whereas a healthcare disparity typically refers to differences between groups in health insurance coverage, access to and the use of care, and of course, quality of care. Health and healthcare disparities often refer to differences that are not explained by variations in health needs, patient preferences, or treatment recommendations, and are closely linked with social, economic, and/or environmental disadvantages which make up the social determinants of health. Traditionally, the most well-known and cited the factors that shape health outcomes are the individual level behaviors like smoking or physical activity, nutrition habits, and alcohol and drug use. That evidence shows are approximately associated with the individual health status and outcomes. However, understanding the social determinants of health, such as they mentioned in the video, requires a shift towards a more upstream perspective, such as understanding the conditions that provide the context within which an individual's behavior is shaped. So to put that in more simpler terms, the social determinants of health are the non-medical factors that influence health outcomes. They are the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. Some of the social determinants of health include income, housing, literacy, access to healthy food options, level of support systems, health coverage, and a whole lot more. A good example of social determinants of health affecting health outcomes is, for example, children being born to parents who have maybe not yet completed high school or and therefore are more likely to live in an environment that poses barriers to health outcomes, such as lack of safety, exposed garbage, and substandard housing. Are also less likely to have access to sidewalks, parks or playgrounds, recreation centers, or even a library. And the reason why this is bad, other than for the obvious reasons, is because evidence shows that stress negatively affects health across an individual's lifespan, and that environmental factors may in fact have multi-generational impacts, in addition to the negative health consequences that stem from exposure to pollutants and other toxic materials. So now that we've discussed the role of social determinants of health and their impact on causing disparities in health and healthcare, I now intend on slightly switching gears and discussing why addressing health and healthcare disparities does in fact matter. And so aside from the fact that addressing disparities in health and healthcare that negatively impact marginalized communities is the right thing to do just generally, doing so would significantly improve health equity more broadly by achieving improvements in the overall quality of care and population health, and therefore ensure that everyone has the right and opportunity to achieve the full potential of their health, regardless of socially determined circumstances and or structural inequalities that are produced on the basis of social identity. So now that we've talked about the significance of disparities in healthcare, I now intend to discuss what is the current status of disparities here in the U.S. So as of now, despite the implementation of provisions such as the Affordable Care Act, which is more popularly known as the ACA, Medicare/Medicaid, and other programs which have brought about some improvements in population health over time, many disparities have persisted and in some cases have even widened. The best example of this is provided by the fact that people of color and low-income individuals historically have faced greater barriers to accessing care, including at a higher uninsured rate compared to their white counterparts and those at higher incomes. Data also shows that disparities in some health outcomes, such as heart disease mortality rates among Black Americans and diabetes mortality rates among American Indians and Alaska Natives, have in fact widened over time. Not to mention, many groups continue to face significant disparities in access to and utilization of care. The best example of this is among non-elderly adults, Hispanics, Blacks, American Indians, and Alaska Natives, who are recorded to be more likely than their white counterparts to delay or even go without needed care. In addition, non-elderly Black and Hispanic adults are less likely than their white counterparts to have a usual source of care or to have had a health or dental visit in the previous year. Additionally, another aspect of health and healthcare disparities in the US that we see today is the fact that some groups are at a higher risk for health conditions and experience poorer health outcomes compared to their other ethnic groups. For example, Black Americans, American Indians, and Alaska Natives are more likely than their white counterparts to report a range of health conditions, including asthma, diabetes, and even heart disease. Infant mortality rates are also higher for Black Americans, American Indians, and Alaska Natives compared to their white counterparts, and Black males have the shortest life expectancy compared to other groups as well. With that in mind, it's also important to highlight that low-income people of all races have been found to report worse health status than higher-income individuals, as I briefly mentioned before, and further research has now recently suggested that some subgroups of the LGBTQ plus community have more chronic conditions as well as higher prevalence and even earlier onset of disabilities when compared to their heterosexual counterparts. So now that we've talked about the current status of disparities in health and healthcare, I now intend to discuss what our current challenges are in addressing these specific disparities. So as I have previously discussed, there have been large gains following the ACA in addition to other provisions, but research still shows that insurance coverage gains have not only been stalling, but have begun to reverse in recent years. In fact, recent policy changes and current priorities have actually begun to lead to continued declines moving forward. The best example of this can be demonstrated by the move at the hands of the federal government to actually decrease funds for outreach and enrollment assistance, the removal of the ACA's individual requirement to have health coverage, and the Department of Homeland Security's immigration policy, which have increased fears among immigrant, which changes have increased fears among immigrant families about participating in Medicaid and CHIP. And if that wasn't bad enough, there's still an array of other challenges to addressing disparities, including a limited capacity to address social determinants of health, declines in funding for prevention and public health and healthcare workforce initiatives, and ongoing gaps in data that ultimately ends up limiting policymakers and medical professionals alike from being able to make informed decisions that reduces the inequity in both health and healthcare. That said, in order to drive action toward reducing disparities in both health and healthcare, it is important that practitioners assume responsibility for meeting their patients' individuals' needs and employing the following techniques. The first proposition I propose is to empower people to make informed health decisions, those people being medical professionals and patients alike through advances in health literacy. Health literacy is defined as the degree to which individuals have the ability to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. And so when people are empowered to, make informed decisions about their well-being, they're invested to make the best decisions concerning their health. The second proposition I propose is to address individual needs through the appropriate screening and referral services. This includes examining how government service and benefit programs intersect on a personal level, and we have to reimagine how citizen services such as healthcare, housing, education, and transportation can essentially work together to improve people's health, well-being, and even their quality of life. The third proposition I would propose is to utilize digital innovations to modernize the delivery of government services. This includes maintaining a focus on improving the citizen experience and delivering more personal and individualized services. And the last but not least proposition I propose is to forge cross-sector partnerships that address the health and social needs of patients, people and organizations at the local, state, territorial, tribal, and nation levels must continue to pioneer new ways to create the conditions people need to ultimately live healthier lives. And so to wrap up this video, I'll end by saying that it is only when all people have the opportunity to attain their full health potential and no one is disadvantaged from achieving this potential because of their social position or any other socially determined circumstance. It's then when I believe we'll be able to achieve this promise of health equity here in the United States. And so I hope that you enjoyed my presentation, and thank you all for watching the video.